For June 13th, which is chapters 10 and 11, which is disability and chronic conditions. We're not having a class period this time, so what I want you to do is after you look at the video, just drop me an email and let me know that you did, and then I'll give you the attendance points. So we're going to go ahead and get started. I'm going to show you some slides and hopefully clarify or illuminate some of the materials in the chapter and maybe kind of relate it to some real life situations too. So let me share my screen with you in just a second. Chapter 10 is disabilities. So let me make this a little bit smaller. Okay, so I'm trusting that all of you can see this. So again, chapter 10, disability. The book talks about this, and I think it's pretty interesting that people with disabilities represent the largest minority group in the US. And disability affects people of any age or socioeconomic status. And oftentimes these people are marginalized by societies all across the globe, and it certainly varies by cultures as well, and they can be subject to stigma and prejudice. There is this YouTube that you can watch if you'd like. It's about people with disabilities that are taking control of their lives and the decisions that affect them. And I think the title of it, or their slogan, is "Nothing About Us Without Us." Because for so often, for such a long time, disabilities have been seen as something, people that we need to take care of, and we need to make their decisions, and we need to tell them what to do. And so this is basically about empowering people with disabilities. And this is kind of along the same lines. What we're doing in this class really is trying to move away from just the medical model of looking at illnesses and differences to more of a social model. And in this situation, with disabilities, we think of the medical model as being more, people being more dependent. And again, the decision-making lies with oftentimes their medical providers, the people taking care of them. Where under the social model, we're trying to empower people with disabilities. So the orientation under the medical model is that disability is a medical condition, but under the social model, it's a disability as a social phenomenon that impacts quality of life. So the idea is that people are differently abled as opposed to disabled. So we try and think of it in a more positive kind of, worldly life perspective. We want, on the medical model, we focus more on problem solving, like, okay, this is a problem, how do we get over it? Where in the social model, we're looking more at kind of life enhancing goals and looking at a person in their whole, saying, okay, this is what we've got, what can we do with it to really enhance somebody's life, as opposed to, okay, picking apart, looking at it as a problem that needs to be solved. And the goals under the medical model are very, how do we make this person as normal as possible? Where again, we're just trying to enhance people's life under the social model. And here's a little bit more about this. Under medical model, disability is seen as kind of an exception to the normal, hence the word disability, dis. And under social empowerment, it's considered more just along the spectrum of normal. And medical model clients seen as victims, and under social model, consumers with rights. There is an international classification of functioning, disability, and health. And the idea here is that, again, to incorporate the perspective of people with disabilities, we portrayed as a result of complex interactions between the individual with a disability and the environment and the society, and reflects the restrictions and our enhancements on access and participation that occur in response to changes, including interventions. So, that kind of goes hand in hand with the Americans for Disabilities Act, which was recently expanded too. So we'll talk about that in a little bit. So disabilities across lifespan, because certainly when we think of disabilities, I don't know what you think about. You might think of somebody with a mental health disability. You might think of somebody in a wheelchair. You might think of somebody that was born maybe with cerebral palsy or cerebral palsy. There's just really, it's such a huge spectrum that it's really kind of hard to put it into one chapter. There certainly are developmental disabilities, and those are the ones where we think of somebody that's born with some sort of disorder. Maybe it's somebody that has autism, maybe a brain injury that occurred at birth, maybe an intellectual disability like Down syndrome, maybe something more physical like spina bifida, or maybe a heart condition. Sudden onset disability, of course, is different. This is where maybe somebody has an accident and they maybe don't have use of their limbs anymore, or maybe they had a stroke or something like that. Under age-related disability, obviously there's different considerations depending upon when somebody has a disability. Somebody that's a young child that has a disability, then the parents play a big role. If it's somebody that becomes disabled later on, maybe they have dementia or Alzheimer's, then the family plays a big role as well, but then it's the children so often. Under developmental disabilities, we think of, the book kind of divvies it out for 3 different kind of age groups, birth to 3. And again, this can be maybe a child that has Down syndrome, or maybe a child that has cerebral palsy, or maybe a child that has visual impairment or hearing impairment. So our focus there is, trying to get involved early on. Certainly with autism, we try and do that. And that involves oftentimes the child's medical provider and maybe other people as well. Maybe there's groups, or there's people who come and help in the home. Maybe there's physical therapy, occupational therapy, things like that. School-age children, it's changed quite a bit in how we deal with school-age children that have disabilities, in that now we have different programs in the schools. It used to be that we would really separate people or children with disabilities, but now under the, I think it's called the Education for All Handicapped Children Act, it requires that children have the least restrictive environment possible. So they're integrated more into regular schools. And then they have, separate classes or separate opportunities to learn kind of more independently as well, paying attention to what their disabilities are. Let me just talk briefly about adults too. So adults with developmental disabilities, again, this might be somebody with Down syndrome as they age, or somebody with autism or Asperger's disease. I don't know if you guys have heard of Asperger's disorder, but it's on the spectrum of autism. And these are people who might not have such a significant reciprocal kind of language issues or learning issues, but they aren't very good at reading people's emotions. And so therefore, sometimes they have social problems. But at any rate, adults with developmental disabilities sometimes kind of get thrown by the wayside. It used to be that we had a lot of residential and kind of quote unquote inpatient facilities for people, which were good and bad. But now we basically kind of send everybody out in the street. So it definitely, for people who had significant developmental disabilities or mental health disabilities, they were kind of thrown out in the street, and oftentimes they end up homeless. Depending on the community you live in, there are different resources available to assist with these people. In Fairbanks, we have the ACCA, Alaska Crippled Children and Adults Association, and Fairbanks Resource Agency as well. Sudden onset disabilities. So this is where somebody obviously has some sort of disability that comes upon them unexpectedly. This has its own share of problems, including loss, grief, coping, and adjustment. Whereas if somebody was born in a certain way, although oftentimes that's a huge loss and grief, coping and adjustment for the parents, but not so much for the child because that's just the way they are. But with adults, issues like return to work and other aspects of being productive, maybe this is somebody who is a primary breadwinner in a family and isn't anymore. So there's lots of issues that have to come into play. There are protections provided by the ADA. And so we as healthcare professionals should know if we're taking care of people with disabilities, whether it's somebody who has a stroke, whether it's somebody who has a spinal cord injury, or even somebody who has a heart condition that doesn't allow them to be active, that we need to know what's available in our community. Sometimes patients might come to you and think they're maybe have been discriminated against. And so it's good to kind of know the basics of these things, especially if you have patients that you're seeing that have certain disabilities. And I guarantee you, all of you will, because their disabilities, as you can just tell from me talking, is a really wide category. Let's see, age-related disabilities. So people as they get older, if they get a disability, and kind of the classic one we think about is Alzheimer's, that they're more likely to have a more rapid decline in function just because they might not be able to compensate as much physically and mentally. We need to remember the comorbidities that happen with somebody, or that go along with people with disabilities. So the idea here is that we don't want to just focus just on what's in front of you. Like if somebody's in a wheelchair, sometimes we forget about what other things might be going on. Does this person have diabetes or something, and we're not taking care of that? Maybe depression, stuff like that. And again, the wellness and health promotion aspect is really important too, because sometimes that goes by the wayside. Maybe we forget if a woman who might have some sort of a chronic disability, that maybe she also needs to have mammograms and things like that. So not to forget health promotion and wellness. Even if somebody's has a disability, we want to pay attention if they're drinking too much alcohol or smoking and things like that. We want people to be as healthy as they can, regardless of their disability. The book talks some about some of the issues particularly in the United States, about health disparities. We do know from study after study that people with disabilities experience worse physical and mental health. And it might be, it's multifactorial, of course. In terms of general practice clinicians, oftentimes we have limited knowledge of disabilities. So often it's an area that we might learn about in medical school, or you might learn about it in nursing school or whatever school you're going to, in terms of what causes a disability and maybe how to treat it medically. But the other parts that go along with it, the social and the environmental issues, kind of don't get addressed. And so, again, if you end up with people, which you will, with disabilities in your practices, it's really behooves you to find out what you can about those conditions. And then also to make sure that that in the clinic that you're working in, or wherever it is that you're working, that there's good access to treatment rooms, exam tables and things like that, because just having a ramp into your clinic isn't enough. If a person can't get into the treatment room, obviously if they can't transition onto an exam table, those are problems. At your front desk, you want to make sure it's wheelchair accessible. So a person, you have an area on your desk, because oftentimes the front desk area has a really high kind of pony wall or whatever, and then the people, the receptionists, et cetera, are behind that. You want to make sure that you have a lower area where people in wheelchairs can access that. We do know that people with disabilities experience poorer physical and mental health. We don't oftentimes give enough time for health encounters, because our time is usually set aside for people of full ability. And oftentimes people with disabilities, they take longer to get weighed. They take longer to get into the clinic room and things like that. So by the time the provider, the nurse, whatever gets in there, they feel rushed. We oftentimes don't get reimbursed as medical professionals for the work that we do. So sometimes there's, I think, less of an inclination to take patients that have disabilities. Of course, people who have disabilities have financial barriers to healthcare, particularly if they don't have good insurance and good resources. There's limited available and access to medical care and wellness and health promotion programs because they're very much geared towards able-bodied people. Oh, that's the end of that slide. I was thinking there was more slides there. But anyway, I think it's a very interesting chapter, and I think you'll, when you read through it, there's a lot more detail, of course, than what I gave here, but I'm just kind of giving you an overview. And in fact, in your homework, I guess I could stop my screen share here. There you go. In your homework for disability, or the videos, I think you'll really like the videos. One is about a fellow who works in California, I think for the Department of Transportation, and he has no limbs, no arms or legs. And he's able to live a productive, very fulfilling life. And he does get some support, but it's amazing what the guy can do on his own. Another short video about a kid that plays piano beautifully who doesn't have any sight. There's those little short vignettes about patient voices for autism. I had problems watching that video though. So if you guys have problems, and I noted this on the homework or in the guided self-study area, if you have problems getting into that, don't spend forever doing it, just skip it. It's not the end of the world, okay? I don't have any direct test questions on that. So, but I thought it was interesting, and I kind of looked at it for a while, and then I'll have to try and look later to see if I can get it to work. Anyway, but most significantly, there's 4 videos called Alive Day, and maybe some of you have had a chance to watch this, but the actor James Gandolfini, which was, he was an actor that died a few years ago. He did some documentaries, and these are 4 of them where he interviews people who came back from Iraq after they've been severely injured, and most of them have some kind of disability. So they're kind of long, they're 15 minutes each, but that's kind of your out of class time here. And one of the homework assignments is to pick one of those people and to talk about their disability, and you can look in the homework about ways that they could be helped and things like that. So I think that that's going to be very interesting for you. Okay, now let's move on to chapter 11, chronic conditions. And let me share my slides for that, just kind of as a guide. This, I think, is a fascinating chapter as well. And I think because one thing I can also guarantee you guys is that you will still see people with chronic conditions. I mean, that's really what a lot of medicine's about. And the end of the chapter goes into chronic pain. And in fact, your homework assignment is to look at a video that I present in the homework area about fibromyalgia and somebody who has significant chronic pain and maybe things that is, and she explains, she's very unhappy with the medical care she's received, and which is not uncommon with people with chronic pain, because general medicine, we don't do very well with chronic pain, to be honest with you. We have, I mean, narcotics, we all know that narcotics have lots of problems, and it's just not an area that we're very good with. And so a lot of people turn to alternative methods for chronic pain. And one of the videos, too, it's not the homework video, is a TED Talk on chronic pain, which is fascinating. I love TED Talks. If you guys don't watch TED Talks and you get a spare moment, just Google TED Talks and you can find so many different topics that are interesting. So anyway, let's kind of move on here. Okay. This doesn't want to, what am I doing here? Oh, there we go. So, in terms of chronic illness, instead of, again, this kind of goes back, there's a lot of similarity in chronic conditions with disability, and particularly coping, because a lot of coping and chronic conditions goes together. But when we think of somebody who has a chronic condition, again, we oftentimes just focus on the condition, where really it's a person's their total of their all life experiences that result from having a disease or injury. We want to understand the client's and family's belief system, right? We've already kind of learned that in this course, that we can't just see the disease or illness by itself. We have to understand how the person views it in terms of their life, their functioning, their family, their culture, etc. Which sometimes, you just might not understand that with the first visit with somebody, but over time, if you keep your mind open and ask open-ended questions and really listen to people, you'll kind of learn those things about them, and it really helps you take care of them. You want to understand how a client and the family chooses to cope with the practical problems, whether that's somebody's being able to walk, maybe somebody can't make their own meals, maybe they need help dressing and things like that. So kind of being able to kind of run a movie in your mind about what a patient's day-to-day life is like. Are they able to deal with daily activities themselves? If not, how do they get their care? Okay. So again, the social, culture, and psychological factors along with their spiritual life is really helpful to know. Illness behaviors. So if somebody has a chronic illness, oftentimes we see several different kinds of behaviors. Now, the behaviors, and the book goes into this, can be adaptable, can be helpful to them, or oftentimes they are maladaptive and they are not helpful, and but they're inevitable, or some of them are inevitable. Sometimes we can measure them. They reflect the client's perception of their own health, though. And again, they can be adaptive. Maybe, again, somebody might use humor for illness behaviors, or maybe there's the illness itself, or maybe chronic pain has kind of taken on a life of its own and becomes a major focus. And so some of these behaviors might be, and these are the more negative ones, verbalizing distress, hopelessness. Sometimes with people, especially chronic pain, they'll oftentimes have insomnia, fatigue. Maybe they'll just need to lie down a lot, so they don't end up, leading full lives. These are more physical things that we might see: sighing, grimacing, moaning, and irritability. So those are just some. And, you can get an idea when you see a person in clinic, unless a person is a really good actor, what their illness is meaning for them. Particularly if people have chronic pain. People with chronic pain don't usually hide that from their medical people. Now, there's acute conditions. We're really not going to talk about these very much, because this whole chapter is on chronic conditions. But again, acute, something that's more of an abrupt onset and doesn't last for a long time, is usually a temporary biological process. People usually have hope for a cure. They can be very positive and proactive about their care. And the treatment and support mechanisms are usually fairly easy. But when things become chronic, it's a lot more difficult. We usually think of a chronic disease maybe lasting more than 3 months. It doesn't necessarily mean it's going to last forever. Okay, depression, I think, is a really good example of that, because depression is by its nature a chronic condition, but it doesn't mean that people, once they have depression, that they're going to be depressed for the rest of their lives. I mean, they can get treatment, or the natural history of depression, even if they don't get treatment, is maybe people will have it for 6 months, then they'll kind of move out of it for whatever reason, but they might get it down the line. So chronic conditions can wax and wane. An example of a disease that does that is multiple sclerosis. So certainly we think of that as a chronic neurologic disease, but it can, people can have remissions and exacerbating times too. Chronic conditions can be visible, meaning other people can see if somebody has scleroderma. In case you don't know what scleroderma is, it's a skin condition that is autoimmune disease where people's skin gets very tight, and that can, and other parts of their body are affected by it too, but you can't see it, like maybe lungs and things like that. But it's progressive dermatologic and other organ system disease can be very serious. Rheumatoid arthritis, which probably most of you heard about, that's a systemic illness that not only involves the joints, especially the smaller joints, but people have other kind of systemic issues with it too, fevers and things like that. So oftentimes you can see the results of rheumatoid arthritis if you look at somebody's hands. Maybe their knuckles or their fingers are deformed. But certainly there's things that are invisible. Bipolar disorder, which is a type of mental health disorder. Diabetes is usually invisible unless somebody's maybe had an amputation. But the idea with chronic conditions, again, in regular allopathic medicine, the kind of traditional medicine, some things we have really good treatment and support for, but other things not so much. Again, we're trying to encourage medical providers to think of chronic conditions as the whole scope of human experience and to pay attention to social, cultural, and spiritual, because these are oftentimes lifelong issues and really can affect a person's life and how they interact with their family and culture and community. We have to keep these other things in mind. Things that really are tough on patients with chronic conditions is the unrelenting nature of a chronic condition. You'll see this when you watch the gal with fibromyalgia, and she's lost a lot of hope too, and she's very depressed. She's angry. There's some other videos that aren't quite as depressing, or as, well, I should say depressing, but as difficult as the fibromyalgia one. There's one on chronic fatigue syndrome, which actually I think that's the first video listed, and that's a gal who really struggled with it, but over time and with help she got much better, so that was encouraging. There's a real brief one on cerebral palsy, which is done by a guy who should be a comedian, and I think you're really enjoying that. And again, the one about chronic pain, the TED Talk one. So you're going to learn a lot about different approaches and different personalities. And of course, it depends on the chronic condition you have. If you have one where you do have a lot of pain or you have a lot of disability from it, then it's obviously going to be more difficult than if you have one that's more mild. Fear of abandonment is common, especially for people who have a lot of dependence on their caregivers, whether it's family, whether it's a caregiver that is hired or that is contracted out, whether it's by you or your family or the community that you live in. Oftentimes, caregivers kind of come and go. They don't get paid near as much as they should. And so that can be very difficult for people when they're used to having somebody care for them and that person isn't there anymore. Book talks about incidents of chronic conditions and how common they are. Relationship with income, particularly people with disabilities, when they have chronic conditions, because of their socioeconomic status, oftentimes they just do not get the help they need. Whether it's caregiving, whether it's getting to appointments, whether it's medical treatment, things like that. And with Medicaid is the insurance that people have that are at the lower end of the socioeconomic spectrum in terms of money. So people who are don't make a lot of money qualify for Medicaid. Unfortunately, Alaska was one of the states that expanded Medicaid with the Affordable Care Act a few years ago. So now anybody, it doesn't have to be, used to just be pregnant women and children, can take advantage of expanded Medicaid, and that's really helped a lot of people get care for chronic conditions. What's our goals of treatment? Well, it's not always cure, okay? There are some things we can cure, but there's diseases like multiple sclerosis, like Lou Gehrig's disease, which is a disease where people have progressive reduction in their ability to move, their muscles become paralyzed. People with Alzheimer's, we know we don't have a cure for that yet. What are our goals? Well, first of all, that's to decrease the incidence and severity of symptoms, right? So I don't know if you guys have heard of palliative care, but palliative care is where we focus on people's symptoms and how we can make them feel better. So it's not always trying to cure somebody. And this is one of the things that hospice does. So when people are at the end of life, the idea is they're not working to cure anybody anymore. They're just trying to help them be comfortable. And we want to improve function as much as we can. So we want people to feel empowered, and if we can do things that allow people to do things for themselves, and you'll see that with the in the disability videos, the guy who doesn't have any limbs, what amazing things that have been done for him that allow him to function more. We want to prevent or lessen the secondary conditions or disability. So we don't want people. If people are getting depressed, or maybe if somebody's in a wheelchair, we certainly don't want them to get bed sores or problems with pressure ulcers, things like that. We want to maximize the quality of life within their existing social structure. Now, we as medical providers, can't wave our magic wand and, make sure that people have a good supportive family and community and the best resources. But if we're knowledgeable of what goes on in the home and maybe paying attention to caregivers, like we learned in the family chapter, then and know about resources, then we can help the whole family. Improve access to leisure activities. So again, that's helping people with function and with mobility and things like that. Other things, providing meaningful choices. Again, working with the person and how they feel about their meaning and purpose in life with their chronic condition. Again, enhance that sense of normalcy, which we talked a little bit in the disability chapter, that trying not to single people out and make them feel different, but instead incorporate it to just what we think of as a spectrum of abilities and health. Foster independent living and promote gainful employment. Like we talked about before, work is good for the soul, and most everybody can do some sort of work, or whether it's volunteer, it doesn't always have to be paid employment, things like that. So again, it depends on your community and what's there, but it's good to know what's available. What are the barriers returning to work? You're going to actually address that when you do the Alive Day assignment, and also with the Michelle, the gal with fibromyalgia. But people have disabilities, whether they're mental health or physical health, oftentimes face social stigma, discrimination. The Americans for Disability Act requires employers to hire people if reasonable accommodations can be made for them to do the job. So if it puts too much undue duress, or if the accommodations that an employer would have to put in place are impossible, or would put too much financial stress or burden on the employer, they do not have to hire a person. So if you don't hire somebody because they're in a wheelchair, yet they could do the job, even being in a wheelchair with minor accommodations, maybe they would just need a ramp, getting into the office, things like that, then they are protected by the Americans for Disability Act. When it comes to mental health issues too, and you'll see this when you do the Alive Day assignment, there are people who have brain injuries. What kind of barriers will they have going back to work? And financially too, if somebody requires a great deal of care and it's very expensive, that can be a barrier to work. Social issues. Again, our society is designed around healthy, fit people. There's a lot of prejudice and stigma. Sense of normalcy is constantly challenged. So we in the medical field are responsible, I think, for advocating for our patients and for advocating for full inclusion into the society, our society, for people who have disabilities or chronic conditions. And again, we talked about barriers for independence. environmental, whether that's people being able to get on public transportation, which can be a challenge, but again, it's much better than it used to be. If they're in a wheelchair, just being able to navigate curbs. In Alaska, with all of our snow, we don't clear up our sidewalks very well, so that's a problem. And again, the social support or the social systems and financial systems like Medicaid, again, that's for people at the lower income levels. SSI is Social Security. I forgot what the I is. Social Security. Well, I don't think it's insurance, but this is where people have a disability that they get SSI for, a monthly check from the government. So depending on your disability and how significant it is, that is a supplemental income for you. And then, of course, flexibility. I think in general, both work and school, people have much more ability for flexibility, like you guys right now. It used to be before we had internet classes, people had to get to class. They had to have their, what we call butt in a seat kind of a thing. Now people, I think it's so much better, whether so many people are able to work from home, but there's still issues there about flexibility and especially kind of the old school thinking. And not everybody, I mean, like I can't do my job from home, right? I have to be here to see patients, but there are more and more telemedicine things available too. So it just depends on the situation. Body image and self-concept. Okay, so when people have chronic conditions, particularly chronic conditions that relate to the way they look and the way they can function, then there are society, cultural, and personal attitudes and belief. Depending on the person, they have their own internal history. Maybe they used to be an athlete and now they've had a terrible accident or a disease and they can't do those things anymore. And that can be a significant hindrance to them depending on their kind of coping strategies. There was a movie, what was it called? You Before Me. It's a book and then it made into a movie about a very kind of handsome British guy who I think was a finance guy. And he was kind of one of those bungee jumping kind of guys, was very active, very athletic. And he got into some sort of an accident where he was rendered a quadriplegic, meaning he doesn't have use of his arms or his legs. And anyway, it's kind of a tough movie to watch, but you think he's maybe going to get better. He kind of starts getting out of his shell a little bit, but in the end, he decides that he just can't live like that. And so really a person's perception of their life and their worth of their life and can they have a fulfilling life really depends on the person and of course their whatever their disability or chronic condition is. And those reactions in their body image kind of depends on if they've had previous losses. Maybe they've had previous losses themselves or in their family and they were able to cope and can see getting through things, how significant the current loss is, what their prognosis is. And the book talks a little bit about patterns of development too, which I won't go into now. You can look at that in the chapter. But and again, your family and cultural values and beliefs, attitudes. If you come from a country like Brazil that puts a huge emphasis and importance on somebody's looks, then that might be more difficult than if you have some sort of disability or changes in your body in another country where maybe that's not seen as important. The U.S. of course values beauty significantly, so this could be a tough place to have some sort of a change to somebody's physical appearance particularly. And again, what we learned way on early in the course about locus of control. If people feel like they have an internal locus of control, they might feel more empowered, where if they feel that their life really is dependent upon their family and their culture, then this can be oftentimes difficult unless they have a very supportive culture and family. And again, that social support is key. Influences on the sense of self, again, alterations in your appearance, belief that a person has that control over their health, that locus of control, how much attention they gave to their body prior to becoming ill. So, or ill or hurt. Like there was a gal, I don't know if you heard about, a few years ago, was a model, and somehow she got out of a small plane and walked right into the propeller. And so she ended up with significant facial scarring. And so, but then she became a spokesperson, I think, for disabilities. And so this is obviously somebody who gave a great deal of attention to her body prior to becoming ill, but she was managed, like we learned in the coping chapter, to kind of give her accident meaning and a focus to her life. And then again, on chronic pain, the intensity and frequency of pain, obviously, as you'll learn about the gal, particularly with fibromyalgia, how that influences her life. And these things all can have an effect on sexual capacity too. And there's a whole chapter on sexuality later on too. Chronic pain. So again, at the end of your chapter, we talk about chronic pain. It's defined as subjective physical and emotional phenomena. We don't really have a way of objectively measuring somebody's pain. We don't have, blood work or little electrodes we can put on somebody. We do know oftentimes when people are in a lot of pain, their heart rate is increased, their blood pressure is increased. And then there's just, the book talks a little bit about different durations of chronic pain. And this is interesting. A TED Talk that you're going to watch talks a little bit about different levels of pain. So some people have chronic pain as spontaneous pain. Maybe it happens for no apparent reason and we can't figure it out. Hyperpathy is more pain than we would expect after a painful event. So say somebody has a hernia repair, and then they continue to have pain that we would not expect afterwards. Hyperalgesia, which means increased intensity of pain to further noxious stimulus. So maybe you've had surgery or some kind of injury, and all you do is just touch the area, and you have pain outside of what we'd expect. Secondary, and you don't need to memorize these things. It's just, this is, you might not realize there's so many definitions of pain. Secondary hyperalgesia is the spreading of sensitivity or pain to nearby uninjured tissue. You guys have probably heard of phantom pain, where people have a amputation and they can still feel pain beyond the area where it's amputated, which is real pain. It has to do with the nerve endings there, and they're doing a lot of research in that. Allodynia is sensation of pain from a normally mild, harmless stimulus. So this would be an example where we just kind of, hug somebody and they have a lot of pain from it. How does chronic pain impact somebody's life? Certainly can affect their sleep, their functional capacity, their social functions. It can certainly impact their finances if they can't work. Oftentimes they're absent from work. Maybe they'll get fired. Depression is very common with chronic pain that doesn't get treated appropriately, and depression in extreme cases can result in suicide. Acute pain can progress to chronic pain sometimes, and we see that on people who have accidents, people who have surgeries, things like that. We know there's a huge mind-body connection with pain, and the book talks more about this, and it's very interesting how our bodies deal with pain, and probably because we can't measure it very well, but we know that the mind has a lot of control over the physical pain that we feel, and trying to help people from a mental health standpoint deal with pain can be extremely helpful. Like maybe you guys have seen videos or heard stories about children in hospitals who are undergoing, say, like chemotherapy for childhood cancers, and they have to have like a lot of IVs. And there are, there's a lot of tricks, I guess, and tips that people who start IVs in kids have for kind of visualizing and doing different kind of meditation and things like that to help them deal with the pain, and that can be very helpful. So it's a huge area of research, and again, we don't have very great medications in allopathic medication. This is an area that I think alternative medicine has helped people a lot. And the symptom magnification is where people sometimes get secondary gain from magnifying their symptoms. And when you watch the fibromyalgia video, different people have different reactions to this woman. Some people feel very, very sad for her and feel like she's, everybody's out to get her. Certainly that's how she feels, I think, in some cases. But there's also, I think, a lot of truth to the things that she's saying, that people don't listen to her. And I think sometimes people they get worn out, and probably her family and friends and maybe her medical people are worn out too. But if you think somebody's magnifying their symptoms for secondary gain, then that can sometimes kind of get in the way of helping people. So what should we do with people with chronic pain, people with chronic conditions? Facilitate the grieving process. So if this is somebody who's had a stroke, or they lost a limb, something like that, give them time to grieve, address the loss. Don't forget about anxiety and depression, and to help them with that. Empower clients to emphasize and use their available resources. So that is, not only does it help you as a medical provider, but it helps the patients and their families too. There are outcome measures that the book talks about, this particular with chronic pain, where since it's so hard to really gauge where people are in pain, there are kind of questionnaires that they can fill out from time to time that kind of helps you and them kind of with goals and with checking how they're doing from time to time using those measures or those questionnaires, etc. Communicate, listen to people. We're already I think I've pounded that into you guys. Educating them, and I think this is what's happened with Michelle, the gal with fibromyalgia. She hasn't gotten enough education and support. Really urging people with chronic pain and with chronic conditions to get counseling, because you as a medical provider, if that's not your area of expertise, there's probably a lot going on that you'll never know. And encouraging people to engage in therapy can be life-saving. And again, don't forget to encourage people to have a fit and healthy lifestyle within their disability or chronic health condition, because everybody can be fit and healthy regardless of their situation. And that's what I have. So again, I forgot to look at the time, but I'm quite sure we're under an hour. So I think I've already kind of mentioned the homework and the videos for this week. I think you'll like all of the videos. They're very interesting. Most of them are short, except the live day ones, but those are, they're really compelling, and some of them are kind of tough to watch, but I think you guys will learn a lot from them. So let's see. Don't forget to shoot me up an email. Let me know that you watch this, and I'll give everybody attendance credit. And I will be back to have a regular class with Collaborate Live on June 20th. And I'll post I will probably post an announcement for that, but you'll just go into Collaborate sessions to access that. I have to use YouTube to do pre-recorded videos, because Collaborate only works if there's somebody else in the classroom with me. So that's why I'm doing YouTube for these. So anyway, that's it. You guys have a great week. Hopefully you're all enjoying your summer, and I'll see you next time.